This is Dr. Subramanya Shetty, Professor, Department of Orthodontics and Dental Orthopedics, Yenepoya Dental College, Yenepoya University, Derlekette, Mangaluru. I am here in front of you all to present a topic which I have already presented in a national conference. Now my topic is autorotation, a truth or a myth, because there is lot of views of an orthodontist regarding autorotation of mandible. We need to know whether the autorotation is a clear concept, is it really happens, or it is just a myth. To know that, we need to know what is the rotation of the jaw. To know anything about autorotation, we need to know rotation of the jaw in detail. Now, autorotation of the mandible happens when you intrude the maxilla with TATs, that is temporary anchorage device, or you can intrude the maxilla by surgical method also. So, when you intrude maxilla, the hinge part of the maxilla which is touching the mandible, because of which mandible was backwardly placed, those hinge is relieved, and the moment you take the maxilla and place a little above, mandible tend to come in the anterior direction. Now that is called autorotation. Before we talk anything about autorotation, let us say what is rotation of the jaw. And before we talk anything about rotation of the jaw, it's our prime duty to know the inside and outside aspect of jaw right from its inception days. So, evolution of the jaw. The first vertebrae never had a jaws. It was called as Ignatia. Then how the jaw was evolved? Jaw was evolved in such a pattern where a simple skull plate was suspended over the bony gill arches. These bony gill arches are the vertical structure which was present in the fish. So, in the initial days, the anterior tooth and even the third arches are disappeared to form the mouth. Now, what is this mouth? Mouth had the mandibular arch upper and the lower part. Now, the upper part is called as palatoquadrate and the lower one is called as Meckel's cartilage. Now, upper half of the mandibular arch become palatoquadrate and lower is Meckel's cartilage. But then how jaw was evolved? Jaw evolved, the lower skeleton Meckel's cartilage started articulating with the back of the palatoquadrate bar. That is the main sign of primitive joints. Now, around the palatoquadrate bar, these palatine and transverse bone which is to carry teeth have started erupting. Now, around the Meckel's cartilage, there are some bones started evolving, that is dentary, angulare, supraangulare, coronoid and condyle lethal. So, this back part of the palatoquadrate and Meckel's cartilage, they ossified to form the quadrate articulate joints. Now, this is also called as primitive joints. Now, in mammals, these new joints created between dentary and the squamosal part of the temporal bone. Now, that makes articular quadrate joint into dentary squamosal joints. Now, these are the diagrams we need to know. Initially, there are gill bars. So, anterior 2 or 3 disappears and forms the mouth, and in the mandibular arch, in the mouth mandibular arch, the lower one is called as Meckel's cartilage, upper is called as palatoquadrate. So, in mammals, a new joint has been created between dentary, which is the only one bone remaining in the lower jaw, because others are fused along with it, and the squamosal part of the temporal bone, the ultimately jaw is shifted from articular quadrate joint to a dentary squamosal joints. Now, these till mammals, these mammals are structured like a quadrupedals, As the days evolved, or the quadrupedals started becoming bipedals, these human beings, what we call as apes, our succeeders, initial succeeders, they have started evolving from quadrupedals to bipedals. Now when they started erupting itself, they wanted to stand up, and from quadrupedal to bipedal, when they started erecting and stand on the ground, even remodeling takes place in the dentofacial structure. That was cranial base bending have started. Now what is cranial base bending? Here initially, in initial days, mammals had a horizontally placed jaws. These horizontally faced jaws started remodeling itself, and the jaws have placed more vertically in a bipedals than quadrupedals. Here what actually happened, or what actually have taken place, is bending of the cranial base. The flexion of the cranial base in such a way that the cranial base started bending according to the gravitational force. Now what happens, why it has done so? Because of this, the cranium in a human being started to get more space to accommodate brain, and brain is the only one active organ which was not there in the other animals. So because of this, humans can think, his sensory issues have improved more than animals. He started getting commanding voice. How the voice have generated? Because of the remodeling of the jaws from horizontal to a vertical pattern, the laryngeal boxes started shifting downwards. So because of this, there is vocabulary chances have improved very well with the Homo sapiens or human beings. That is the reason for both the jaw to retroposition from a horizontal pattern to a vertical pattern, or it is even more retroposition. Maybe here we can say only one disadvantage here is, yes, we had a little compromised airway compared to other animals. But our intelligence skill have improved, our locomotive sensory issues have improved than other animal. Speech, we started getting commanding speech for the Homo sapiens or human beings, where we can communicate better with the others, where the animals cannot do that. Now if you see this slide, the aerodynamics of the face have changed from horizontal directions to vertical. Now initially the jaws were placed more horizontally. As the days evolved, the skull as well as the jaw have undergone enormous remodeling, and it has placed in such a way that both the jaws have retropositioned, and you have more cranial, intracranial space in Homo sapiens than animals. So because of this, human being can think, he can act well, he can communicate well with others, and he started getting very commanding voice, and moreover anything, God has made us a beautiful creature like Hrithik Roshan, like this. Now let us see what are the jaw rotations, because to know anything about autorotation, it is very wise to know what are the rotation of jaws. Now in early 50s, Bjork has made some studies. He has traced radiographs and he has used implants to know where exactly the rotation takes place. So growth rotation changes can be seen superimposition true tracings of lateral cephalogram that was taken at different times of point, and sometimes the intervals between them was around 6 months to 1 year. So he has focused in these three main points. There are many authors, not only Bjork, Profit, Hudson, Bjork, they all did studies on the same aspect. But when there was radiographs being taken in two different time intervals, black lines indicates the initial or a pre-growth, where the blue one is indicates the radiograph is repeated after 6 months or 1 year after the initial thing. No, I missed it. Okay. So, if you want to know anything about growth of the jaws, to know anything about autorotation, it is wise to know about rotation of the jaw before in hand. Now, in early 50s, Bjork had made some studies using implants. So, he used these implants in the corpus of the mandible, and he started taking series of X-rays in a different time intervals. Example, 6 months or 1 year. So, these are the main 3 lines he focused. One was cranial base, the second was implant line, which was mainly focusing the corpus of the mandible, and last one was the soft tissue border of the mandible line. Now, he has taken 2 intervals radiograph in a different time aspects, and he started comparing it. When he started comparing this, mainly the cranial base, he kept it as a standard point. He noticed that the corpus of the mandible and the lower part of the mandible, there are growth rotation is been taking place. So, you can clearly see there are some difference in the corpus line and the mandibular border. Now, authors have started naming it in a different way. Prophet said cranial base to corpus of the body, he said internal rotation. Hudson said no, it is true rotation, and Bjork said it is a total rotation. Now, angular changes in the implant line to the cranial base. Now, when angular changes in the mandibular line relative to the cranial base, it was called total rotation by Prophet, apparent rotation by Solo or Hudson, matrix rotation by Bjork. So, again when he compared different X-rays in a different time intervals, the implant line, that is corpus of the mandible, to a lower border of the mandible, the superimpositioning on the implant line representing the core of the mandible, and angular changes can be appreciated in the lower border of the mandible. Now, angular changes in the mandible line relative to the core of the mandible, now that is called external rotation by Prophet, angular remodeling of lower border by Hudson, and intramatrix rotation by Bjork. Now, when you want to summarize these 3 events by different authors, it would look like this. Bjork has classified rotation of the jaw in 1969, 2 types, forward rotation and backward rotation. In forward rotation, there are again 3 subclassification, type 1, type 2, type 3. And however this subclassification has taken place, it was according to the center of axis. When the center of axis lies in and around condyle, the mandible rotates forward and anteriorly by getting deep bite or decreased anterior facial height. When the center of axis lies between 2 tips of central incisors, then the anterior facial height remains constant, but the posterior facial height increases. So, this will also subsequently causes underdeveloped anterior facial heights. In the type 3, because of the large overjet between upper incisor and lower incisors, the center of axis shifts from incisor tip to the premolar region. When it happens so, anterior facial height again remains underdeveloped, but posterior facial height increases, by causing decreased anterior facial height. This is all about forward rotation. Now, this was the type 1, type 2 and type 3. Type 1, you have center of axis around condyle, type 2 you have center of axis around incisal tip, and type 3 it is moved just distally in and around premolar, that is because of the large overjet between upper and lower incisors. Now, another type is backward rotation. Now, in backward rotation, the center of axis, though it lies in the condyle, the remodeling happens in such a way that mandible started moving backward and downward. Now, in this situation is mainly because of many other factors, like when orthodontist himself gives an appliances which causes increase in the posterior facial height. Now, by giving bite blocks or any other appliances make the mandible move more downward and backward. The another part is mainly because of the flattening of the cranial base. Now, if the cranial base, middle cranial fossa is underdeveloped, then automatically your mandible also moves more upward direction by leaving the symphysis of the mandible more downward and backward. The last one is decreased development of the middle cranial fossa or the cranial base may also cause the backward and downward rotation of the mandible. Now, this is all about forward and backward rotation of the jaw. Now, these diagrams tells us about structural signs of mandibular growth rotation, one with the basal deep bite, another one with the basal open bite. So, with this we will come to know the direction of the rotation of the jaws in a different pattern. Now, Prophet said there are total rotation, matric rotation and intramatric rotation. Now, matric rotation, so growth is happening around the condyle, and intramatric rotation growth is happening around the corpus of the mandible. So, now there is another great man called Shetty. He also spoke about rotation of the mandible resulting from growth. Then what did he say? He said jaw grows in two directions, clockwise and counterclockwise. How is that now? Now, clockwise he compared vertical eruption of the molar to the condylar growth. If the vertical eruption of the molar is less compared to the condylar growth, then the mandible tend to grow anteriorly and upward direction. This will make us more closed bite. In case if the vertical molar eruption pace is more than growth of the condyle, then mandible tend to rotate more backward and downward. This is the main concept given by Shetty. Now, this is the beautiful diagrammatic illustration of concept of intramatric rotation which is given by Dibets. According to him, the framework around the painting remains same, though painting may rotates inside the frame. Now, this means there may be an enormous remodeling happening inside the corpus of the mandible, but the outline of the mandible looks the same. This concept, this beautiful concept was given by Dibets. Okay, we have brushed all across remodeling of the jaws and rotation of the jaws till now. Now, let us come to the part of treatment modalities which may cause autorotation. Now, what are the things to or what are the treatment modalities we can do to get autorotation are as follows. TAT supported, that is temporary anchorage device supported. In a growing patient we can use headgear and we can get the changes to bring about autorotation. We can also use functional appliances with modification, extracting the distalmost tooth to reduce wedge effect. Another one is we can use exaggerated coroscopy in the lower arch and reverse curve in the upper arch, and also superior impaction of maxillary jaw by a surgical method. By doing all these things we can bring about autorotation. Now, you all can see, now this is a lateral ceph where the maxillary plane is like a aeroplane is just about to take off from its runway. If it is in that direction, then your maxilla is causing hinge effect on mandible. The normal angle from n perpendicular to maxillary plane is in between 84 to 88 degree. If anything more than that or any deviation from that angle, then your mandible causing the hinge effect on a lower jaw that pushes the lower jaw more backward and downward. So, this is the main key points you have to look in the lateral cephalogram whenever you are in a verge of treating treating the malocclusion. So, as I mentioned earlier, what to look in the radiograph? These are some treatment modalities. Here, altering the maxillary plane cant with occipital headgear in a growing patient, thus causing the autorotation in mandible. So, after clinical examination in lateral ceph, if you have an aeroplane takeoff mode, maxillary plane, by having posterior upper 6 intacting with the lower 6, that is the posterior upper incisor, the posterior upper molar is intact on the lower molar, pushing the mandible more backward and downward. So, if you eliminate this, you may get autorotation. So, let us see what are the cases we have treated in our department. Now, this is the first case have come to us with the complaint of irregularly placed upper incisors. When we went on with the diagnosis with the various methods, radiographic, photography and other methods, we come to know that there is a slight open bite tendency with the crowding in the upper and lower arch. We also came to know that the posterior teeth of upper is hinging on the lower posterior teeth by pushing the mandible more backward and downward. So, we decided to use an extraradicular screws, that is IZC, infrazygomatic screws in the upper, and buccal shelf screws in the lower. So, we have put a force, or we have generated a traction of the force in such a way that we get anomalous posterior intrusion and anterior extrusion. By doing this, we have closed her open bite tendency. We have treated her in this fashion. She was very happy. This was her smile. You can see the comparison of profile pre and post. These are the treatment we have done to her, and these are the intraoral pictures, and these are some analyses where we know that FMA has changed drastically from 40 degree to 35 degree. We could manage to decrease FMA. So, by bringing the mandible more anteriorly, thus causing autorotation. Now, facial axis angle also changed. Now, these are the values. These are the soft tissues analysis we have done. We have compared both pre and post, and when we do the superimposition, we came to know that mandible has auto-rotated in very good extent. We could close her mandibular plane angle, her open bite tendency reduced. Now, in another case, this patient also had come to us with the ugly smile. His complaint was mainly about ugly smile. Doctor, please fix my smile. When we went ahead and did the analysis on him, we came to know that he was having a short mandible with proclined upper incisors and even a mild proclination in the lower, but it was more like upright lower incisors. So, these are his OPG and lateral ceph. We tend to, we decided to advance his mandible using fixed functional appliances like forces. So, when we did that, this is where we came and landed. Still we were not happy because we could not achieve the proper occlusion what we wanted to. Then we decided to reanalysis him by taking lateral ceph again. When we came to know that his maxilla is again excess, so we decided to intrude his entire maxilla by giving 4 implants. His entire maxilla is intruded. As soon as we intruded the maxilla, mandible auto-rotated. And this is a smile from all the way from bird smile to this beautiful smile. We could achieve very good result with him, and these are his lateral ceph and OPG. These are some comparison photos from pre-treatment to the post forces, that is fixed functional appliances. Then from there to post treatment, that is after intrusion of maxilla, autorotation of mandible has taken place. These are the smile comparison. Patient is really happy. These are some values we need to know. Again here see FMA is changed from almost, it was 32 degree, we could manage to reduce FMA 2 degree, that is 30 degree, facial axis reduced. So when you do superimposition, we can see the autorotation of the mandible. Mandible is nicely moved anteriorly. Now this is the ideal way to treat the class 2 cases. So here what I want to say is we have to be in a wise position to judge the case when it comes to us, like where exactly the points we are looking for. So if there is a rotational jaw, if there is a problem with rotation of the jaw, where the matrix, intramatrix and total rotation, if you are remembering, I was talking about it in the earlier slides. If the axis, center of axis lies within the corpus of the mandible and the lower border of the mandible, then there is no chance of auto-rotation. This happens only when your center of rotation is somewhere near condyle also, and these things are happening because of the hinge activity from upper molar to the lower molar. Because of that hinge, your mandible is pushed backward. Then you can think of doing auto-rotation. Otherwise, it is not possible. It is simply not possible. There are many factors, other factors like genetics also plays a key role in this. If we have a very great degree of jaw rotation, then it is impossible to create auto-rotation. Now let us see what are some rotation of the jaws we have done. This is one more case. Before rotation of the jaw, I want to show you one more case here. This is another case has come to our department. She was having a gummy smile with the proclined upper and lower incisors. Same way we have treated her, we came to know that posteriors are having a slight hinge activity with the lower molars. So we thought of intruding her entire maxilla by using 5 implants. So we used 4 implants buccally and 1 palatally. Here one photo is there where we used TPA, modified TPA with the 2 hooks. So we placed a palatal implant there, and from that implant we gave an attachment palatally and also buccally from the buccal implants. By doing this, we could intrude her entire maxilla. This is her profile. The treatment is still going on. We have not debonded this case, but this is the change, dear friends. So you can see a great momentum of mandible has happened here. The mandible moved extensively, to a anterior direction, and she was having a large lower facial height, was managed beautifully here. Her lower facial height decreased. It is comparable to the middle and the upper 1/3 of the face. Normally we say equal, upper 1/3, middle 1/3 and the lower 1/3 should be equal. In her earlier photo you can see upper 1/3 and middle 1/3 is equal, but lower 1/3 of the face was more. We have managed to get that in a normal limits here. This is one of the beautiful cases we have treated in the department which by auto-rotation. So here also FMA reduced 2 degree. So this is the auto-rotation. Mandible has greatly moved ahead, and we have maintained our occlusion also. Case number 4, I want to show in this, other than auto rotation, what are the other things we can do. Here it is vice versa. Here the lower facial height was slightly reduced, compared to the upper 1/3 and middle 1/3, and patient was having a mild crowding and kind of deep bite. So she was having impacted 8s, and also we thought of extracting all 8s and distalizing entire arch. Why so? Because she was horizontal grower, her lower facial height was decreased. So we wanted to intentionally cause the rotation of the jaw here. So we wanted to retract in such a way that let the hinge activity takes place posteriorly, so that mandibular plane angle opens. When the mandibular plane angle opens, the decreased lower facial height will go for the normal one. Now that is why these are the results. Her lower facial height slightly increased to a normal limits. These are her finished photos. These are the X-rays, radiographs, post radiographs, and you can see here mandible plane angle jumped from 22 degree to 25 degree, and LAFH have increased from 62 to 64 degree, 62 to 64 mm. It is a great change, and these are the profile comparison, from decreased low facial height and the proper one. Here you can see the low mandible have rotated downward and slightly backward, because we have distalized upper and lower arch by using extraradicular screws. This is the last case. He has undergone orthodontic treatment somewhere else, and then he had come to us with a great version of poor oral hygiene. So we have sent him across to the other department called periodontics. We have taken their guidance and we have done some deep gingival scaling, root planning, and we recalled him again. We saw some mild bone loss, generalized bone loss was there. So we have taken perio guidance and started the treatment. Again here we are using some extraradicular screws, and we could manage to finish him in this pattern. So here also we have done distalization of both the arches without changing his lower facial height. So we have not much changed this lower facial height. You can see FMA from 34, we still maintained 33. So we have not worsened his lower facial height. So what I wanted to say is, we can decide and we can design the treatment modalities according to us when we are very good in diagnosis. So key point is all about diagnosing the case. Now this is a superimposition. You can see mandibular plane angle has not moved much. So these are some articles I wanted to let you know. These are the beautiful articles given by some great authors in different journals. And there is one more article I wanted to tell you all regarding auto rotation, how to gauge or how to calculate auto rotation. This is this article, Farzad Piromazad. He has given a beautiful idea about how to calculate auto rotation, because when we are in a verge of surgically impacting the maxilla, we have planned for surgical impaction of maxilla without an idea about auto rotation, then we will be in a soup. So this gentleman has given us a beautiful calculation how to calculate auto rotation. By keeping auto rotation in mind, we have to impact maxilla and do our orthodontics mechanics. So that is the reason we have mentioned that article in our presentation.